Some of these are just memorization questions, which we'll go through, but we'll hit the important ones. Sometimes I like to throw up pictures, but again, the picture should be obvious. Keep in mind the vignette often has enough clues that you don't have to depend on the picture. They like to test you on like which type of congenital hand deformity type it is. I don't know this. I don't know. I passed my hand board, so just take that as a grain of salt. They will ask you. But the most common one they'll ask you, failure of formation, it's like if the hand didn't form something, that's pretty obvious. And they don't say it's not just like class 1. It'll say class 1 and then a type. So they're not going to ask you to remember what type 1, type 2, type 3 are. Overgrowth makes pretty much sense. Undergrowth, so brachial syndactyly, that's short, syndactylized, attached fingers. Constriction band syndrome. Construction band syndrome is really bad. Sorry for the typo. But constriction band syndrome is its own type. So the most common one, which sometimes is hard to remember because it doesn't make a ton of sense, is failure of differentiation. So why does differentiation mean syndactyly, where you have fused fingers? It is what it is. So most of the other ones you can sort of figure out when you're going through the test. The key thing to remember is failure of differentiation is a lot of variety of different issues, syndactyly being one. They also like to ask a camptodactyly, which we'll go over. So failure of differentiation is syndactyly. Other things in terms of development, 4 weeks, that's when your limb bud is present. At 4 weeks, there's already a growing limb bud. At 8 weeks, your hand has fully formed and has separated digits. So all of that takes place in a very, very short period of time. Around 8 weeks, and all this time is a key portion for most of fetal development. And so your kidneys and everything else is forming at the same time. That's why if a kid has a severe hand deformity, then you may want to look to see if they have other congenital deformities, because everything's happening at the same time. They like to ask the 8 weeks thing for syndactyly. They'll ask what time in fetal development did this deformity occur? It's got to be between 4 and 8. So you can eliminate anything else. And it's not like they're going to go week 5 or week 7. It'll be within 4 to 8, and then anything else should be outside of that. They also like to ask, so there's the different parts of the limb bud which control your hand formation. So the zone of polarizing activity, the ZPA, it controls radial ulnar differentiation. So thumb, small finger. And it expresses sonic hedgehog. I don't know that they'll ask you about the concentration, but it is more on the ulnar aspect of the limb bud. And the sonic hedgehog gets released there and diffuses to the other part of the limb bud. So high concentration of sonic hedgehog gives you more ulnar portions of the hand, and lower concentration gives you more radial. So low concentration of sonic hedgehog is the thumb. Apical epidermal ridge, that is FGF. So that's one of those stupid, the memorization things. So ZPA, sonic hedgehog, apical epidermal ridge, FGF, that is proximal to distal. So if you have a longitudinal arrest, it's your apical epidermal ridge. And BMP is also expressed by this, and BMP, for whatever reason, is involved in digital separation. So BMP disorder, or BMP is involved in syndactyly. And then wingless proteins, or WNT, WNT, that is dorsal ventral. So palmar, dorsal. This is just rote memorization, but those are the key points. All right, polydactyly, very common. It's mostly ulnar polydactyly is most common in African Americans. It is autosomal dominant. And I apologize, the slides are either out of order. At the presentation, you guys should have an updated presentation that Michael put on the Google Drive. That is this particular presentation. I think the slides and the ones you got printed out may not be, they've got cleaned up in between, or there's an old presentation. So the severity of your ulnar polydactyly does not necessarily have any implication on the likelihood of having another deformity. It just has to do with how you treat them. If it's most commonly periodic skin bridge, you can tie them off in the neonatal new unit. I don't like to do that because there's an incidence of neuroma formation, and it's usually a more unsightly scar, but it's still some places considered standard of care. If there's bony attachments, then you have to take off the bone, obviously. But the key thing is ulnar polydactyly, no concern for genetic disorders. It just runs in the family, and that's what it is. Radial polydactyly, or the so-called, most commonly the Wassel thumb, which they'll talk to you about, is rare, much more rare than ulnar polydactyly, but more common in Caucasians and Asians. So this is the Wassel classification. It's sort of, again, not worth memorizing. Just think of a systematic way to approach it. You just start with the distal phalanx, divide that partially into two. So there's two tips to the distal phalanx, and that's one. Bifid distal phalanx is one, and then you just march it down. Then you divide two totally distal phalanx. Two distal phalanxes are two. Bifid middle phalanx, 3. Duplicated middle phalanx, 4. On and on. The key thing is at 7, it diverges, and 7 is a triphalangeal extra thumb. That is important. So you march it back to the metacarpals, and then 7 is a triphalangeal. The other thing to remember, most common is 4, and the key thing is the evens, the 2, 4, and 6 have a duplicated joint surface. So you have a widened proximal joint, and you have 2 separate bones distally. The implications for that is that you have to reconstruct the ligament structures of that joint. That's sometimes something they ask. So you preserve the ulnar digit usually. It's usually the larger of the two. And then for the 2, 4, and 6, where you have the intra-articular duplication, you need to preserve the radial joint ligament from the finger you are throwing away to then reconstruct the radial ligament on the finger you're keeping. Sometimes they ask that. Triphalangism. So triphalangeal, or type 7, that is when you have an increased incidence of genetics problems, other disorders associated with the radial duplication. So radial duplication is associated with the genetic problems, whereas ulnar is not. And it's the triphalangeal duplication, which is the most common, or an odd duplication. So if it's really weird, 3 extra digits, think genetics consult. So what are the associated conditions? Fanconi's anemia is one of the common ones. So that's when you want to not operate on somebody, a kid who has a weird duplicated thumb, without checking a CBC or referring them to genetics consult, because they, you need to know this. This is life-threatening. Holt-Oram syndrome is another one. So that is heart defects and a radial-sided abnormality. More commonly than a duplicated thumb is like a radial club hand. So severe radial deficiencies. TAR syndrome is thrombocytopenia absent radius. So again, anytime if they show you an x-ray of a kid or a description of a kid who is an absent radius, it would be absolutely insane if they ask you the treatment of radial club hand. I wouldn't waste your time trying to memorize it when you have all the other stuff to do. That's a question you can afford to miss. But just think absent radius. The easy one to get is think genetics consult. That, you want that, or they need a full evaluation by their pediatrician. All right, hypoplastic thumb. So this is the hypoplastic thumb classification. It goes from small to a narrow web space to losing tendons to now having some bony problems. So type 2, 3A, 3B. Treatment for a small thumb is nothing. It's small thumb with a narrow web space, or they have deficient thenar musculature. You're going to increase their ability to oppose with replace the deficient thenar musculature, so opponentsplasty procedures. When they have weak tendons, but they have a key thing here, stable CMC joint, you can do tendon transfers to improve range of motion. And then now anything why they decided 3A and 3B, where you have now an absent metacarpal base, needed to be a separate type. It doesn't make any sense to me, but Blouth gets credit for making it complicated. The key thing is, as soon as you do not have a stable CMC joint, you have to do a policization. That's it. There is no other option for that. So it seems like 3B should be 4, if you ask me. But the key thing is you would do the policization around 1 year. So this, they will show you, you remember, this is a kid, you're not going to be able to see a trapezium on x-ray. So there will be a clinical vignette describing an unstable thumb, unstable CMC joint, or a floating thumb, or an absent thumb. The key thing is there's no other treatment for that patient other than a policization, and you want to perform that around 1 year. All right, syndactyly. BMP pathway involved. For whatever reason, overexpression of BMP is associated with syndactyly. Again, 7 to 8 weeks gestation is complete formation of the hand. Complex syndactyly is when the bone is also fused. Soft tissue only is simple syndactyly, and they can be complete, which is all the way to the fingertips. Incomplete, which you see here. Sorry for the photo editing, but you have not a complete syndactyly. It is divided, separated distally. So you want to separate, let's say they give you, there's also acrosyndactyly, which is syndactyly associated with congenital band syndrome, or also sometimes Apert's, which is much more complex. And in any of those, you may have proximal clefts. So you have distal fusion, and you actually have a proximal cleft. They might show you a picture with a cleft, and there'll be like an instrument through the fingers proximally. That is more associated with a congenital constriction band syndrome, and it's sort of a different entity. But the key thing for this is you can only separate the fingers as much as the arteries let you separate them. That's the key thing for some of the more complex Apert's hands. You want to separate your border digits first. Why is that? Is you have differential growth of your fingers. Your middle, the central fingers are about the same length. Anything on the border, like if your thumb is fused with your index finger, your thumb is going to retard the growth of your index finger. Same thing with your index and middle, and think about your small and ring. So you're sort of, is pulling its neighbor back. And also, obviously, for thumb, you want to get it out as soon as possible. The key thing I like to ask is, how do you appropriately reconstruct the web space?